Hello, and welcome to our session today, Integrating Diversity, Equity, and Inclusion into the Improvement Journey. I'm Dr. Tejal Gandhi, Chief Safety and Transformation Officer at Press Gandhi, and I'm joined by my colleague, Deirdre Mylod, Executive Director for the Institute for Innovation and SVP of Research and Analytics at Press Gandhi. Our agenda today is to first talk about the Press Gandhi Equity Partnership. We'll then talk about segmentation of data to identify inequity. We'll talk about assessing the quality of your administrative data and then a strategy for moving forward. So I want to start with this concept of inequity really as an issue that needs to be addressed in order to achieve our goal of zero harm in healthcare. There's no such thing as high quality, safe care that is inequitable. So we need to bring the equity lens to all of the work that we're doing in quality, safety, and patient experience. And we know that inequity can cause harm to both patients and caregivers. For caregivers, it can lead to physical harm, emotional harm, diminished engagement and resilience, and an increased risk of burnout. For patients, it can also lead to physical harm and emotional harm, as well as poorer health outcomes and worse engagement as well. Certainly, we have seen this impact of inequity playing out with the COVID pandemic. We've seen large inequities in rates of infection, hospitalization, and mortality in the United States. And we've had differential impacts on African American and Latino populations, for example, in lots of different measures that you see here on the screen. Globally as well, we're seeing that there's increased risk and impact on poor and underserved populations. So COVID has really highlighted the fact that we need to have this focus on inequity, and again, both for patients and the workforce. One thing that I've been thinking about a lot, given my background in patient safety, is that there's a lot that we've learned in patient safety in the past 20 years that can really help us advance equity. And inequity needs to really be looked at as a systems-based problem that requires a systems-based approach. So what do I mean by that? First, we need to think about how do we design our systems to make them more reliable and resilient in general, but in this case, how do we make them more reliably equitable? We need to balance system and individual accountability, which we've spent a lot of time in patient safety thinking about. We have to recognize the role of often subconscious biases. We have to really highlight the need for psychological safety so we can have difficult conversations about race and racism and bias, just like we've had difficult conversations about medical error. And there must be a focus on strong leadership and culture to help drive this work forward. Another thing that we need to really focus on as we go forward and try to make an impact on inequity is that data stratification must become the norm. Once you start looking at data stratified by race and ethnicity, you start to identify important differences that you may not have ever known about before. And that starts, then you ask the questions of why these differences exist and start to think about what are the right interventions to put in place to try to narrow those differences. And so what I show you here on the screen are various data sets that have shown these kinds of differences for different populations. So for example, the maternal mortality rate in 2018 for non-Hispanic Black women was about 3 times higher than for non-Hispanic white and Hispanic women. And that's an important difference that we need to be able to see through this stratification and then start to understand. Similarly, even in things that we've been looking at for a long time, like hospital-acquired infections, if you start to segment the data, one study showed that Asian and Hispanic patients had higher rates of hospital-acquired infection on the safety side. Again, without that segmentation, we would never know this and never be able to start thinking about the appropriate interventions. Another really important point that we have to think about, especially as we think about high reliability, is that we need to ensure that the systems approach, the high reliability approach, the solutions we're putting in place are not unintentionally widening inequities. And this graphic from the RWJ Foundation really highlights that. With equality, where we're giving everybody the same intervention, you may actually widen the gap. Whereas with equity, and you give differential interventions, you achieve fairness. And so we have to think about approaches such as standardization or technology that may be a great intervention, but we need to appropriately measure and monitor to make sure that we're not widening gaps unintentionally. So based on all of this, we launched our Press-Gaining Equity Partnership in July, and we're really excited about this partnership as an opportunity to help have us be able to help clients to really reduce inequity in healthcare systems, leveraging our data, expertise, and technology solutions. So this partnership is free of charge to all clients, and it has 4 components. The first is that we are working on new data analytics using artificial intelligence and natural language processing to help clients better understand the themes and sub-themes that may be identified when we start to do segmentation and really start to think about what quality improvement might look like. And that data analytics piece will include both quantitative data and qualitative data, because we have so much comment data that also, if you segment that, you can start to identify themes in the comments that may differ by race and ethnicity. Second, we are working to create new standard data formats and have implemented an equity data diagnostic really meant to optimize the capture of race and ethnicity data. We've learned that the capture of this data can be very variable. The quality of the data can be variable. There can be a lot of missing data, non-standard data. And so the purpose of this data diagnostic is really do a deep dive into the data that you're capturing and that you're sending to us and help you identify opportunities to improve the quality of that data. Third, we're looking into the questions that we are asking on both the patient experience and workforce side to see if there's better ways that we can ask questions around bias and inequity for patients, clinicians, and the workforce. And lastly, we have created learning forums to identify and share best practices for improving equity in healthcare organizations, and really to have opportunities to learn and share and hopefully not reinvent the wheel as we're all advancing on this journey. On the client side, clients really need to commit to just work with us on all of the things I just mentioned. So develop and implement systems that enable capture of the data needed to drive improvement, upload that race and ethnicity data to us, participate in learning forums, and respond to the analytics findings to address gaps in equity in healthcare with your leadership. Some of the disparities that we're working actively to address are the items that you see in bold. And I will say before I go through those that we're beginning by focusing on race and ethnicity with our data diagnostic and our analytics. Certainly, we plan future work that would encompass greater intersectionality with other elements such as gender identity, sexual orientation, language, etc. But we're just starting with race and ethnicity. And the disparities we're going to work to address with the partnership include, as I mentioned, differences in patient experience by race and ethnicity, differences in workforce engagement and resilience by race and ethnicity. And the last one that we're just starting to explore is also patient bias in their evaluation of their experience with clinicians. And are there ways that we can better understand how that bias might manifest in patient experience scores for clinicians? So I'll mention that one as one that we are just getting started on, but that there has been a lot of interest in from many of our clients. And with that, I'm going to pass it over to Deirdre.
Thank you, Tejal. I'm going to talk in a little bit more depth on some of the measurements and research elements of the partnership and the things that Press-Gaining has been working on so that we can bring you richer data. And Tejal mentioned we're starting with race. And on the next slide, we have a quote from Ibram X. Kendi from How to Be an Anti-Racist. And it helps us think about the need for segmentation by race or ethnic variables. It can kind of give us pause to think about segmenting by race and ethnicity. And in an ideal world, not just healthcare, but in an ideal world, if everything in culture were equitable, we wouldn't need to segment. We wouldn't have to look at different groups. We would simply treat everyone the same. But in a world that has inequity, and we know that ours does, it's important to conduct this type of segmentation because we have to find and address the problems. And it's summed up in this quote by saying, if we stop using racial categories, then we will not be able to identify racial inequity. Terminating racial categories is potentially the last, not the first step in the anti-racist struggle. So it's really important work for us to do. And for some of us, it's new work. Now, when we start to talk about racial inequity. The next slide shares because as we've talked with organizations, many folks have shared the concern, if we find inequity through racial differences, does that mean we're saying our organization is racist? Does it mean we're saying that care is racist or the people providing care are racist? And that line of questioning, it comes from an authentic place of concern, but we think it arises from a definition of racism that's too narrow. That concern starts with the idea or the defining features of racism being conscious acts that are perpetrated by one person toward another person with an intent to harm and an intent to discriminate based on race. And that's way too narrow of a definition for racism. It ignores the impact of history, of policy, of past lived experience, and it implies that racism is really just a problem only of individuals and how they behave, if they behave in an intentionally racist way. Now, racial inequity can arise from conscious acts that are based in prejudice, but racial inequity also can come from a lot of other sources. Individuals' behavior can be unintentional or unconscious. Racial inequity can come from differences in lived experiences. Social determinants of health are often talked about as the source of inequity, but they're actually not the source. It's the power and wealth gaps that cause those social determinants that may be the source of the inequity. And then at the farthest back level, the policies, the initial policies that created, perpetuated, or are failing to rectify inequity of those social determinants. So there are a lot of layers that we need to explore, and this is not just about individual behavior or categorizing a group as good or bad. The other reason, on the next slide, we call out the idea that when you segment, it's an exercise in empathy. Segmentation and looking at experiences for different groups, whether it's different clinical groups or age groups or racial or ethnic groups, it helps us develop empathy because you need to be able to imagine the experience of another person in order to put yourself in their place. You can't be blinded by your own experience or your expectations of what their experience is. So it's a really good step and a concrete step in the development of empathy. Now, Tejal mentioned several things that we're working on: segmentation, measurements, standardization of coding and administrative data, and I'm going to go through some examples of each of those. And this next slide brings up an example of segmentation. This comes from some recent analysis of workforce data, and it highlights really clearly why it's necessary to segment to uncover differences in experiences. What this does is it takes a diversity module. We have a validated diversity module. It's available to anyone who's using our engagement services. And the diversity module asks respondents to describe their perception of the culture of diversity, equity, and inclusion within their organization. And what this analysis does is it segments what's the score on that total composite, the diversity module, for different groups of individuals, whether they're Asian, Black, or African American, Hispanic or Latino, or white, not Hispanic. That's over on the right. And it also tells, showing these rows are showing the analysis for each different job category. And it also shows in the bar graph the proportion of individuals who fall into different communities of membership. So what we're seeing here is healthcare, like many other industries, is not equitable in terms of who are in leadership positions or positions of relative power. The service roles we see, this bottom row of service, has the most diversity, but the clinical roles and leadership are more likely to predominantly include individuals who identify as white. This is very common in other industries as well, but it means that we can be blind and not understand the experience of other people if we don't specifically seek to look at what those experiences are. What the diversity module findings are showing is that for every job category, individuals who identify as white are more likely to feel favorably about the diversity, equity, and inclusion culture at their organization. But those individuals who identify as being Black or African American are the least likely to feel favorable within every job category. So if you're in leadership, and if you are more likely to be white in leadership, and you have a more favorable view of your cultural diversity, you won't know what your colleagues of color are experiencing unless you ask them, and then you segment the responses to see what their experience truly is. Now, on the next slide, it gets a little bit of a teaser of the notions of intersectionality. Here we're looking at both racial and ethnic groups as well as gender. And these data are showing some of the key metrics from the engagement tool the measures that go into the overall engagement outcome. And what we can see is data for nurses over on the left, data for physicians over on the right. The scores are reflected for each of these measures in the engagement composite. And what the bars are showing is where are the differences for female clinicians versus male clinicians. And what it's showing, the red bars are showing that for nearly all of these scenarios, women are reporting a worse engagement, worse experience in their work environment. The only situation in which things are positive is nurses who are white, their metrics are higher if they are female, but for every other group, engagement metrics are lower, sometimes dramatically lower if you're female. And so this gets at that idea of how important it will be for us to extend into elements of intersectionality, whether it's the clinical group or the gender or some of the other variables that Tejal mentioned, but it's just a little bit of a hint of some of the good work to come. On the next slide, we're going to shift into patient experience data. And these data were from a national study that we conducted in order to submit comments to CMS as part of their maternal equity work. And what it does is it takes HCAHPS data from a national sample. It reorganizes the measures in terms of patient needs. And so the courtesy questions are together, the information questions are together, so that you can easily look down the view, the profile, and see where are differences based on the theme of the question. And again, the idea of intersectionality here, the moderating variable is the service line, maternity, and then medical and surgical care. What we're seeing is differences in top box scores. It's just a simple subtraction, and it's comparing individuals who on the survey identify themselves as being Black or African American versus those who do not, because HCAHPS allows patients to identify themselves in all of the communities that they belong to. And so when we compare just top box scores of patients identifying as Black versus those who don't identify as being Black or African American, we can see that for maternity patients, top box scores are lower for nearly every measure, sometimes dramatically lower. For medical and surgical, sometimes predominantly the scores are more favorable. But given what we know for maternal outcomes in this country, it's very concerning to us, and it's very obvious that there's work to be done in enhancing the maternal experience, especially for some really important elements of discharge prep, understanding and managing health, understanding medications, being told about symptoms to watch out for. That would be critical for helping women have healthy birth experience, post-birth experience, and being able to take good care of themselves and their child when they go home. Now, exploring that theme of maternity care a little bit further, the next slide looks at the medical practice setting. Again, we've organized the measures in terms of patient needs. So questions related to information are together, questions related to empathy are together. And this takes more of a system view. This is the kind of thing that we're working toward automating so that your organizations can look at these kind of visualizations easily. This uses the Press-Ganey Medical Practice Survey, and it's looking at the difference in how women who are identified by the organization as identifying as Black versus those who identify as being white, how their scores would rank as compared to the national database, and what's the difference in their rank. And this is just for women going to see their OBGYN. So again, we see a very compelling story that women who identify as being Black or African American are having a more negative experience. We can see that across all of the measures, but we can also see that there's some measures that have even more dramatic gaps. And it's concerning because staff work together to care for you. How well staff protected your safety? Again, given what we know about maternal outcomes and safety for these women and their babies, this is very concerning. And also importantly, the measure how well nurses listened. And I want to call that out because leaders in the birth equity movement have reviewed this data with us. Dr. Joya Crear-Perry, and what she shared is that when she's conducted focus groups with women of color that are having maternal experiences, she said that they've commented, you ask us if we trust our doctors, but you don't ask us if our doctors trust us, if their doctors believe them. And this is an opportunity for new measurement. So as we move into the next section, I wanted to kind of call out that idea that Tejal mentioned, that we want to really get more creative in exploring the potential for new metrics. We do have a lot of metrics that can be segmented. It does paint a very full picture, but we may not be measuring everything that we need to measure. And this idea of being listened to, and more importantly, being believed, we think is going to be really critical. Now, on the next slide, there's a rather academic reference. about the idea of epistemic injustice, justice related to knowing, and the kind of epistemic injustice or injustice related to knowing is testimonial injustice. That's the one that I want to talk about for a moment. It's the idea of the definition, prejudice that causes a hearer to give a deflated level of credibility to a speaker's word. A simplistic example of this is if I call my IT department and I describe what's going wrong with my computer, and they say, well, did you shut it down? Yes, I shut it down. You're not listening to me. You're not hearing me. You're not giving credibility that I'm accurately telling you what's going on. That's a very simple and almost a flip example of testimonial injustice. But testimonial injustice does real harm. People that are in positions of authority, if they do not believe what you say because you are Black or because you are in a particular community, that does harm to you, and that is a tremendous form of inequity. And that's something that we think we need to explore in terms of new measurement. Now, on the next slide, there's some quotes from a recent article that was in the Chicago Tribune. It explored this topic, and it really brought out this theme in a really compelling manner. And it had example after example of patients saying that they were reporting symptoms, raising a concern, not being taken seriously, not listened to. And the quote at the end really just capped off the whole topic. 9 times out of 10, I was completely brushed off, he said. If there were ever a book on medical racism, it should probably just be called They Don't Believe Us. So we're really getting serious about exploring how we might tap into the measurement of being believed as part of the equity work. Now, on the next section, we're going to shift from the data that we want to report out and the measures that we want to develop into what's some of the homework that we need to do in order to make sure that those segmentation, those analytics are working the best and really are optimal for your organization. So we know that segmentation only works if we have good data by which to segment. Sometimes we have patient self-report, and that is the gold standard. So on the CAP surveys, patients do self-report both their race and ethnicity. But for many populations, we're relying on uploaded data that comes from your administrative record, from your electronic health record. And that's where we need to know that that information is present, that it's reliable, and it's of high quality. And on the next slide, it gets at some of the very specific attributes of the quality of administrative data. So part 1 of the equity data audit is looking in fine detail at the quality and the information that's in your upload. It's looking at, are you sending, are you providing, along with the patient record, information about race and ethnicity? If you're providing it, are the data complete and filled in? Are there many blanks? Are there many unknowns or declined? And we know that patients should have the option to decline, but if there's more than 20% of patients declining, it's likely that not all of those patients have actually been asked. We're also looking at the consistency of the labels. So are you using consistent labels across the system, consistent labels within the facility? Often we see that as organizations, with all the ways that organizations are evolving, some might be on one medical record system, some on another. Sometimes within a facility, a service line might be pulling their data from one portion, of the billing system or the MedRec. And so there can be a fair amount of inconsistency. And sometimes it's little things like labels that reflect the same groups of membership, but are spelled or abbreviated differently. And all that just makes it harder for you when you go to segment your data. If you wanted to run a query today in Query Tool, segment your data by race and ethnicity, you have that information available to you. But if those labels don't match up and they're not tidy, you're not going to get the best information out of there. Also, if those labels are not readable, if they're all ABC 123, on your data side might know what that code is, but the end user can't immediately use that information. And so we strongly recommend that the labels be text-based and readable. And then we also, we like to talk through with organizations the granularity of their labels. Now, at the broadest level, the CAPS tools ask about race in very broad terms: white, Black, African American, Asian, American Indian, Alaska Native, et cetera. Some organizations, though, when they have large populations of particular groups, so Middle Eastern, North African, Chinese, East Indian, Lumbee, they might be uploading those much more specific elements. And we'll talk in a moment how we're going to be able to accommodate that and be flexible, but also be standardized. And then finally, we're really strongly encouraging independence of the race and ethnicity variables, that they should be two separate variables as they are on the CAPS tool. When organizations combine them and you have a race field that also denotes Hispanic identity, you missed out on those individuals also being able to have a race membership and being able to pull people in and allow them to identify all themselves in the way that makes most sense for them. Now, part two of the equity data audit, which is on the next slide, is getting at the notion of accuracy of the data. Now, for that, we take the inpatient data. We have a great test case. If you're uploading, and many of you are uploading race, and patients are self-reporting race on their HCAP survey, we can do a quick comparison. And we do that comparison in two different ways. So for accuracy, we think about it first, is the label correct? If you have identified me as white, do I agree? Do I say that I'm white on the survey? Are you correct? And we look at that, what is the proportion of correct labels? And we also look at it by race. And what we're finding is that most often white patients are most likely to be correctly labeled. And the correctness tends to be a little bit lower for other racial groups. So there's inequity in our equity data, and we need to address that. The second element of accuracy that we look at is the inclusion of the right people. And that's kind of coming at the same question, but coming at it from the opposite angle. So where correctness is, if you say that I'm white, do I agree and confirm that you're correct? Inclusion is, if I say that I'm white, do you know? Have you included me? And those rates in general tend to be lower. We don't include everybody that should be included in groups because we're not asking everybody, we're not getting full and complete data all the time. And the inclusion rates also differ by race. White patients who identify as white are more likely to be included in their appropriate racial group than other communities. And that's, again, something that we need to address. That way we'll have the best information by which to segment the data and really explore patterns. Now, on the next slide, we share a little bit of some national data. As we're working with organizations to optimize their uploaded data, we're also doing quite a bit of research to bring insights and national patterns. And so I just wanted to share with you a little bit of that. So across the different survey populations, we've started to tabulate and document what proportion of client organizations are sending a race field. And then how does that translate into the proportion of patients that might be sent, that might be captured within that administrative data? That's going to give us some sense of the national studies and the regional studies that we'll be able to bring to you. That'll help you see how your patterns fit into the larger context. And then on the next slide, there's additional national data, and it's looking at that one of those elements of accuracy, the correctness. So when an organization is identifying patients in these different broad racial groups, what proportion of patients, what number of patients are in these groups, not nationwide, but what proportion of patients are identifying as that same race as they were categorized in? So on their HCAP survey, they have checked a box that matches something that's in your administrative data. And here we're seeing that pattern that I described a moment ago, that white patients, the data tends to be more accurate. 91, 92% of patients who identify as being white confirm that the organization, they don't know they're confirming it, but their data confirms what the organization has in their administrative data. And those accuracy rates are a little bit lower for these other groups. And again, that's pointing to the need for more training, more standardization, and more rigor around collecting this information to get into the administrative data. Now, a note about that, when we provide insight about this accuracy or opportunities to improve accuracy, the great thing for organizations is it's not just helping you with your patient experience data or your workforce data to segment, it should help provide insight and optimize all of your equity work. So if you're looking at hypertension rates for different racial groups, you now have the idea of, oh, my administrative data is not quite where it needs to be. And the work that you do to optimize that will help across all of your clinical quality and safety measures. Now, I'm going to spend a moment in the next section talking about some of the behind-the-scenes work for creating additional capabilities in reporting in meaningful groups, but also allowing for flexibility so that your organization can be uploading data to us in that race field. You don't all have to send exactly the same thing, but we're going to create a way of tidying those into meaningful groups. And the next slide shows an example of the idea of granularity. And I mentioned that a little bit earlier, but here's some sort of physical examples. On the left, we have a list that many organizations would be using. This would be the broad racial groupings that reflects the same kinds of things that are on the CAPS tools or for the CMS measures, various quality measures. And those are the most broad categories for race. And there's nothing wrong with stopping there. Those are the big buckets, if you will. But other organizations are providing in that IT race variable, they're providing a list that might look like what's over here on the right, a mixed level of specificity. So some of the labels do reflect a broad racial group, like Asian. Some reflect a nationality or nationality of descent, like being Chinese or Lumbee. Some are reflecting different regional groups of nationality. So the regionalism of being Black or African American is a broad group, but African is a subset of that. It's a regional group, or Middle Eastern North African. And many organizations send quite a bit more numbers of different, very specific groups. And the call to do that is really based on what you're capturing. Are you capturing it today, or could you capture it? What's the size of the populations that you're serving? Are you going to have meaningful numbers that would reflect, that would have enough sample size for you to look at? And do you think that there could be a reason that these groups have different needs, or that our ability to meet their needs is different? And now I'll say that those considerations are for reporting. It's always a good idea to ask people and allow people to identify themselves in the way that they choose. But in terms of how much specificity you send over to us, that's really a matter of how are you going to use it strategically for your reporting. So if we've got all this mixed level of specialty coming across in data, how are we going to maintain your flexibility to do just that, but also get these labels into tidier groups? The next slide shows a little bit of a visual about that. So we can think about the broad racial category. So over on the left, we've got the entire broad racial category or the geopolitical countries that would fall under the category of being Asian. In the middle, we have a regional group, so East Asian. And then over on the right, we have a nationality, being Chinese. And we can see that these can nest within each other. So that what this will allow us to do, this nesting idea, will allow us to take flexible data that you're sending over and put information with as much information as we have to put people into each of these groups to allow for reporting categories. So there will be new reporting variables that relate to nationality, regional group of nationality, and broad racial category. The next slide shows a visual of that, how that nests. That's just the idea of the broad racial category, then the regional grouping. And then the next slide builds and shows how those would work out for each of the broad racial groups. Now, in this situation, we've listed only one example of a nationality underneath. So Lumbee under American Indian, or Iranian under Middle Eastern North African. Obviously, there would be many, many nationalities that would fit under each of these, but we just wanted to show one as an example. And finally, on this topic, I just wanted to show you how this would play out if you were sending data in an upload that had this mixed level of specificity or mixed granularity. So if you imagine that you were sending the data over in the left column, the uploaded, the way that the reporting and the converting into these reporting variables, we're going to leave your data exactly where it is. So if you're using your race uploaded variable today to segment your data, you have nothing will change for you. We're not going to overwrite your information, but we're going to grab the information that we can from that. And we would be able to say, for example, that if you say someone is Chinese, we can say their nationality is Chinese, their regional group is East Asian, and that they are Asian. If they're Japanese, nationality is Japanese, but they're East Asian and they're Asian. And you can see how this will all flow. And that way you'll be able to choose what's the specificity that you want to look at and easily toggle among those. Now, at this point, I'm going to turn the presentation back over to Tejal, and she's going to talk a little bit more about the improvement component.
Thanks, Deirdre. So I am going to talk about driving improvement from the data, because our real goal in all of this work that we've been talking about around segmentation and data quality and really getting into the weeds on how the data is coming into us, but our real goal with all of that is to drive improvement. And we can't lose sight of that particular objective. And so I'm going to take us maybe a little higher level to start to think a bit more at the strategic level about how we really try to advance our work on equity across patients and the workforce. So we absolutely need to work on these details around the data, but in parallel, need to be thinking about what our broader equity strategy is and how that's going to drive the improvement that I just mentioned. So here are some components to an equity strategy. This is not all inclusive, but just some things that we wanted you to think about initially. And I'm sure all of you will be creating your strategies or already have a strategy, and you can look at this and potentially add or tweak based on what we talked about. So first, really thinking about how equity is embedded into your mission and values as an organization, and tying that into also, is there leadership accountability and really support across the board, including your board, to advance this work on equity. Culture, as I mentioned at the start, is really critical. There needs to be significant part of your strategy on culture, which includes things like transparency, potentially around the inequities that you're identifying, as well as the psychological safety to have difficult conversations, just culture to avoid being punitive towards individuals, but really thinking about that focus on systems. You also need to think about strategically, what is the right infrastructure that you are going to need to develop to advance this equity work? Is it multidisciplinary? Is it going across silos? And really, is it embedding equity into all activities that you're doing in the quality, safety, patient experience, workforce engagement space, and population health and other areas as well? And so, in safety, for example, are you really thinking about how equitable is safety reporting, or are you bringing an equity lens to root cause analysis? There's so many other examples as you think about your engagement work or your population health work or other domains of quality access, for example, or effectiveness. And I think, again, we want to bring the equity lens to all of this work, and then also think about how we can break down silos between some of this work. So an example that I'll give you is shown here, where if we look at perceptions of diversity, we find that they're strongly correlated with safety culture. Perceptions of diversity are also strongly correlated with engagement. And safety culture is strongly correlated with engagement. So that was a lot of correlations, and this diagram on the right really demonstrates that these things all flow together. If you have a strong perception of diversity, you're more likely to have a strong safety culture and strong engagement. Or if you have a strong safety culture, more likely your workforce will feel that you have a diverse and inclusive environment and be more engaged. So these things flow together. And so as you think strategically about your work, think about how you could combine efforts with cross-cutting initiatives that would actually work on safety culture, perceptions of diversity, and engagement together, as opposed to having 3 different teams doing 3 different initiatives on these 3 different topic areas. So it's really important to start to understand the synergies of combining some of these efforts. Other components to your equity strategy include, of course, the data and analytics piece that we just talked about, data collection, data segmentation, and dashboards, and thinking about how you're presenting this data at all levels of the organization, from the units or front lines to leadership and the board. Education and training of the workforce is certainly going to be a key component of this, and we've seen many organizations already doing training around unconscious bias or training around how to ask questions about race and ethnicity, and so that will need to be a significant component. Community engagement, this is an area where many organizations have really been leaders of how do we truly become partners with our communities, work on things like social determinants of health, living wage, supporting local businesses, and other types of partnerships. And so that's, I think, a true strength that we have already with many organizations around the country. And then lastly, thinking about improvement initiatives, leverage a robust improvement methodology. I'll talk a little bit about high reliability in a moment, which is a methodology that can really be applied to equity, just as we've been applying it to safety. Have clear targets and goals for improvement. Involve patients and the workforce in co-designing interventions. Deirdre talked about the voice of the Black mothers and the way that they're describing that they're not feeling heard. And we need to talk to patients and the workforce about these issues and learn from them what might help them feel better heard, as opposed to designing our interventions in silos away from the people that they're really going to impact. And as I mentioned at the start too, really looking for those unintended consequences. Unintended, as I'm describing, we're not meaning to widen gaps, but we need to be really thoughtful and measure and make sure that that's not happening. So as you think about this improvement work in particular, with our goal to really get results on equity, high reliability can really be the chassis by which we do this. We've often talked about high reliability as something in safety, but high reliability is really just making sure we are performing something as intended consistently over time. And that could be your strategy, that could be the way you're developing people, the way you're caring in terms of quality and safety, the way you're improving, et cetera. High reliability is the method or the chassis to perform that as intended consistently over time. And all of those high reliability methods that have been talked about can really be effective for whatever you're trying to improve. And we've talked to many organizations at Prascania about really creating a high reliability operating system. That this is the operating system by which your organization operates. And again, that is being used for whatever domain you're trying to improve in. And so as you think about your equity strategy, think about high reliability and improvement methods and how you're going to bring those to this work so that you can most effectively use the data and analytics to inform and then drive continuous improvement. So in conclusion, we really believe now is the time to integrate equity efforts into all that we do. And it's essential to create an overall strategy for this effort and ensure integration. The equity partnership and all of the work that Deirdre described will help with data quality, standardization, and segmentation to allow for more robust analytics on both patient experience and workforce engagement data. And then we'll identify opportunities for improvement and will also provide many opportunities for learning and sharing best practices. I can't emphasize this enough. There's many organizations out there that have done incredible work in this area and some that are maybe a little earlier in their journeys, and we need to make sure that everyone is learning from each other. And as I mentioned, the analytics that we'll be helping to do must absolutely then drive improvement, and high reliability principles and improvement methodologies can really be the chassis by which you can drive that improvement.